Okay, so what we are going to discuss today are the all important points regarding the module, the module wise as well as domain wise. We are going to discuss the 5 domains with you, that what you need to do in different domains, particularly for the face-to-face exam. We will highlight those points which are important in the face-to-face exam. And these domains are the patient safety, communication with the patient and relative and with the colleague, information gathering, and clinical knowledge. We are a group of 4 mentors, Dr. Ambreen, Dr. Huma, Dr. Fozia, and me, Dr. Khalda. Today we are going one by one. The mentor will discuss the one by one the domain. And then after that, we will do 2 tasks. We need 2 volunteers from beginning. You can put your name in the chat box, those who are interested to volunteer for the task. At the end, we will have 2 tasks. One will be done by Dr. Zubia, one by me. And before that, we will discuss with important points regarding the domain wise. So I will give it over to Dr. Huma, that if she want to say anything.
Thank you so much, Dr. Halda, and welcome all of you, the member candidates. And we wish, all of us wish that everything good in the world just comes back to you, and you will be a successor and victorious in passing this exam, and we will celebrate along with you. Now, the thing which will be a little bit different in this current exam, that will be a totally face-to-face exam. Previously, there was online exams. Still, RCOG is running the OSCE circuit, which is the final revision courses, OSCE circuits online. But the examination is face-to-face. So we are coming back to the previous routine where we started this, and because of the short time, although it was a very good experience for some of the candidates who were not able to spend a lot on the traveling and the hotel and accommodation, all these things, it was very good for all of them. But still, some of the candidates, they find it, the face-to-face exam, much more better and the good experience as compared to online, because of the technical difficulties. Anyhow, the important thing is this, that when you are going, when you were going through the online examination previously, only you were having encounter through your face and through the screen with the candidates and the role player and as well as the examiner. And you can, you can skip, and you don't have to look at the face of the examiner while looking at the screens. But in face-to-face exam, you have to face the examiner. You have, even if you don't want to, you will just try to have a look and see how the examiner is reacting. And believe me, some of the examiners, they have very blank faces. They are very mask-like. They will not nod on your conversation. They will not show any sort of reactions. But don't bother yourselves about all these things. Just concentrate, because if you will start looking at the examiner's face and you will expect that they are going to show you some expressions, they are going to nod their heads and give you some sort of, tips and tricks, then it's not going to happen in the face-to-face exam. They are supposed to sit silently in a corner and watching and observing you. Even the most important is the lay examiner. The lay examiner, they are the persons who are not connected to the medical field at all, and they are meant to see your communication. So the communication skills are very much important when you are going through the lay examiner stations, because the lay examiner has got a lot of marks for your communication, your body language, your the way you are dealing with your patient. So you have to be very much expert on that. So my advice for all of you would be, start doing the cases with your friends, with your study partners, through the videos, while having the face-to-face encounter. Don't do it blankly. So you should know when you are going to face the patients in the real exam. So don't confuse yourself. You won't become nervous. And like most of the girls which I see, when we are doing the cases, they don't like to switch on their cameras. They just want to switch off their cameras. They don't want to show themselves. You have to be very much confident, bold, to face the people, to face the camera, and to start the examination. Now, the rest of the things we will discuss in the domains, and we are going to open up with the domain-wise. I think, Dr. Halda, would you like to add something, or we should start on?
I think we should start further. So you are the first. I will share first your slides so that you can start.
Yeah. Okay.
Okay. So new share. Let me check where are those slides. Stop this share. Mhm. Now you can see my screen.
Yes. All of us. I think I believe everybody can see it. No, okay. Thank you. So
Yes.
my domains to be discussed today, they are the communication and patient safety, and these two are very much important domains as you are going through face-to-face examination, especially the communication part. Because as you know, in the face-to-face examination, you show your communication not only the verbally, but only also through your emotions, through your body language, through your gestures. So it's very much important that how you are going to communicate with the patient and the families. Obviously, when you introduce yourself and you start for the introduction, that is the start of your communication with patient and families and with colleagues as well. So in the communication part, we have two sort of communications in the exam. That is the communication with patient and families, and second is communication with colleagues. So communication with patient and families, you will see mostly this sort of domain is given when you are going facing the simulated patient task. And when there is a structured discussion, then the part comes with communication with colleagues. However, I do believe when you are doing the simulated patient task, when you are communicating with the MT team and you are involving your seniors, you are also doing communication with the colleagues in that part as well. But important thing is this, that when you start your communication, you should have the understanding of the situation awareness, where you are sitting, how you are going to communicate, how we are going to open up your conversation, because you should know either you are sitting in an emergency ward, you are sitting in a postnatal ward, you are facing an angry patient, you are breaking bad news, or you are going to bring some cheerful news to the patient, you are facing some depressive patient, the mentally ill patient, or you are going in sitting in infertility clinic where the patient is under a lot of stress. So situation awareness is very much necessary for your communication, because the way you talk with the patient, either you are going to be apologetic, you are going to be cheerful, sharing some good news and asking, giving the congratulation message, or you are going to do the breaking bad news, so you are going to do the signposting. And if you are dealing with the angry patient or there is a risk management case, then you are going to be apologetic. So this is the communication way, how you are going to start with the patients. So your communication starts with the information gathering, history taking, and discussing the diagnosis, communicating results with the patient and the families, and breaking bad news, know when, where, and how to, and what not to communicate. You should know the limitations, where you should talk about, and when to stop. Don't discuss the irrelevant things, because the RCOG wants you to give the very focused sort of information. So you have to calculate and you have to practice the domains according to the time. So don't waste your time over the things which are not required. And you have to, with the communication, it should be an interactive one. Empathetic, interactive, and cheerful. The lay examiner is going to see that how you are talking to a person, how you are going to build a rapport, how you're going to gain the trust of a baby. If there is a minor who's coming for the the case of sexual abuse, how you are communicating, how you are maintaining the confidentiality. And if you are not a good communicator, your role player will not open up. They will not share the information which are being like a hidden agenda or something they want to share up, unless you are very much interactive. You keep on asking questions and giving the checking the understandings and inviting the questions from the patient. They will not going to tell you something which is the most important. As far as the communication with colleagues is concerned, as you know that you are going to discuss with the if you're going to do with the examiner, it could be a structured discussion, it could be a teaching station when you are teaching with your junior, with the midwife, with the nurse, or any medical student. And as well as communication means it's not only the verbal, the communication is through the written communication as well, which is through the form of the discharge letters, referral letters, MDDT letters. So there are a lot of ways how you are going to communicate with them. And as well as the sharing information with the patient, that is at the end when you say that I'm going to document your information, you are communicating with the patient, you are giving them the results with the GP, midwives, other health professionals as well. Can we go to the next slide, please? Okay, central to this is the ability to take the patient to a level where they are able to understand what is happening to them and use information provided to make an informed choice. Most patients we see are frightened, and the way we may tell them and what we may offer them in the terms of treatment, making the patient feel less frightened, sought to be an integral to our clinical responsibilities. A well-informed patient is easier to manage. Do not forget that this particular domain may be assessed by a lay examiner. The keys to successful communication includes introducing yourself and your role in the care of the woman, referring to the patient by her name, ask whether what she wishes to be called, listening and answering questions, I'm being attentive, making use of both visual and auditory clues, sympathizing, empathizing, if appropriate, understanding anxiety is not imposing for patient who disagree. So you have to recommend and treatment and the exercising patients, and never lose your temper with those who are angry, aggressive. Next slide, please. Okay, like if you introduce yourself and your role, for example, I'm a doctor dash dash and a specialist trainee, and confirm the simulated patient name and possible ask how she would like to be addressed, explain why you are here. I will be giving you, asking you question and explaining the symptoms you have and group investigation, and we are going to make a combined management plan. This role is explained with depends on the task. Work out the best way to communicate in non-medical terms. You have to use the simple terms, simple language, no medical jargons while if you're discussing with the patient, but you should know that if you're talking to a medical person like examiner or the trainee, then you have to use the medical terms. So this is the thing which you have to change swiftly when the task changes. Be prepared to justify everything you say, which includes able to make an argument for and against, including convincing a patient to change her mind, but at the same time, be prepared to acknowledge differences and accommodate concerns of the patient. Avoid giving too much information at the same time. This could potentially confuse the patient. Break it up and pause to ensure that there is an understanding, inviting questions, inviting understanding, ask in between, do you understand? Are you with me? Is there anything which you want me to clear up? I'm here to help you. Conclude by asking if there is any unanswered question, you are just going to ask from them. Summarize the things, and then the patient which you have covered, and ensure these things are being well understood by the patient. Communication with the colleagues is just as important as with patient and relatives. This main difference is that this is with professionals, and therefore the language should be professional. Key to this is the brevity, being very precise and knowing just what is not relevant. The important thing in this structured discussion is this, that when there's any question, please do understand the questions, because in structured discussion, the examiner will have 5-6 questions. And when they start with the first question, what is your initial management? Please listen and hear and see initial management. Just stick to the initial management. The girls, once they start summarizing the case, and they're going to give, I'm going to this, that, and diagnosis, treatment, investigation. They won't stop. They give all the information within the first question, and as a result of that, the examiner is not able to answer the things which he or she wants to ask. So please, it's a evolving sort of viva. So they are give answer in small chunks and only to the question which is being asked. The initial management is stay to the initial management. Then ask the then just keep yourself silent, and the examiner will come up with another question. Okay, so communication could be with the colleagues at the trainee level, senior colleagues, the same specialty colleagues in other specialty in the form of referrals, handovers, seeking additional expert opinion, midwives and GPs in the form of letters, discharge summaries or referrals. Here, it is important that the candidate is able to write a good letter, understand the referrals and the contents of such a letter should be. The most common form of communication is between colleagues of one shift to another, that is a handover, and that is in the form of SPAR. So you should know what is SPAR and how to do a not common means of assessing communication colleagues is teaching. This may you involve explaining a task to the learner or on a junior colleague by other professional, for example, example, midwife or nurse. The principles of teaching must apply, that you are going to check the background knowledge, you are going to rule out the bullying and the undermining, and you have to ask what is the purpose of this specific task to be learned by the trainee, and what are the benefits he's going to get there. And then do encourage the knowledge and the keen and the zest of the training that she wants to learn, and give the practical demonstration. And also don't forget at the feedbacks at the end of the teaching, whether how the session went, whether it's went well, or whether she needs something else to be learned, and can be another session can be arranged. Okay, now the next slide is the SPAR. As you all know, that SPAR is the communication tool which we do while with the labor board, gynae board, and the handing over. And even if you are going discussing some cases with the examiner, as you know, this is S is the situation, B is the background, assessment, and recommendation. So this is a little bit brief of that. You can go through. We're going to share the recording afterwards. Please, the next slide. So now comes the patient safety. The patient safety is a very, very much important in RCOG. They will not pass you, even if you pass applied clinical knowledge, information gathering and communication, everything. But if you are fail in patient safety, they will not pass you. So just try to be a safe doctor. This is very much important. And the safety starts from when you enter into the cubicle. The safety starts from there. They want to see that starts from the situation awareness, whether you understand where are you sitting, what is the case, what is the ward, what is the patient doing, whether the patient is vitally stable or not. Are you going to get the whole information gathering from a patient who is vitally unstable and just doing the agenda and the things, how may I treat you, what is your name, how can I help you, just tell me your session, and your patient is collapsing. So the safety is this, that you know the situation, the patient is in pain, patient's vitals are dropping, she has tachycardia, saturation is low, blood pressure is low. This means the patient needs the resuscitation first, and then the information gathering. So this is the safety, that you understand you are a safe doctor. You know what are the things which are being offered to the patient. And obviously, when you introduce yourself, you give your name and you ask the patient, you confirm the biodata, whether you are talking to the right person, the NHS number, date of birth. So this is the start of your safety, that you are confirming the person which is the right precise to whom you are talking about. Then there are a lot of things which for the patient safety, you should know that issues on Data Protection Act, mental capacity, child protection, when and how, to whom you are going to call for help, and then issues of confidentiality, cultural and religious factors involving care, order and clinical governance, WHO checklist, safe prescription and prescribing errors, confirming the results belong to the patient, confirming the details on the results are the patient's, unlicensed medication. When you are giving some medicine which is unlicensed, do tell to the patient this is not licensed, but there are clinical trials for that. I'm going to give you that. Ensuring that patient health is not jeopardized, contraindication to the management, etc. Complication rising from the treatment or failure to treat, consenting for surgery, who, what, and when to consenting. Prioritization of care, inpatient, outpatient, labor ward, waiting list. Can you please just scroll it up? Dr. Khalda, can you just take, okay, yeah. Prioritization of results. So when you are breaking bad news, you should know that whether what is the time when to break the bad news, whether to get information first or give the news first. Or, these are the things which you are going to prioritize while you are going to discuss with the patient, and you are going to ask from the patient what she would like to hear, whether she would like to hear the news first or whether she would like to share the reports first. Okay, just please scroll it up. So as I'm telling you, safety is in all domains, starting from introduction till contact groups, information leaflets. When you're giving the contact groups 24/7, hospital contact number, information leaflet, these are all part of safety. You are a safe doctor. You are giving the contact to your patient in case of any emergency, where to contact, when to contact, and to whom to contact. So as I have told you that the things which you are already, the rest of the things which, according to domain wise, which comes that you are going to confirm the date of birth, the age of the patient, BMI of the patient, because you are going to see whether the patient needs any prophylaxis for the VT or not, allergies when you're giving any sort of drugs. So this include not only the medicines allergies, it also includes the food allergy, the metal allergy. If you are going to do some cases with the copper coil and the nickel allergy, if you're going to give the HRT, then food allergies. So the peanuts allergy, anything which comes under allergies, you are going to ask from the patient. Any then supports. It's important to know whether your patient is well supported, whether she's supported financially, who's at home, whether if it's an epileptic patient, you should know that there is enough support at home. If she has got fits, there's somebody, it's a safety, that you are a safe doctor in looking at all the perspectives of your patient, whether the patient is financially supportive or not, whether, if there is a person who is seeking for the infertility and they are not financially, whether they are able to finance their IVF procedure, the IUI, and all these things you should know. And as well as if the thing, something which is urgent care needs arises and the patient is not financially stable, then you are a doctor who is going to involve the social services to provide the finance support and all these things to the patient. Then the emotional, as you know, for the pregnant women, we ask the woolly questions. So it's very important to know the mental status of the person, whether she's going through any depression, anxiety, and she needs any urgent care, the community mental health team. So these are all the things which comes under the safety. So, and then you have to rule out any hidden agendas like sexual abuse. In case of minor patient, the girl, she is a minor, or if a lady comes to you, you have to rule out the domestic violence and the sexual abuse, and you have to make it rest assured the patient is safe to go home, whether there's safeguarding issues and involvement of the child protection lead, the police, and as well as the fetal genital mutilation. So there are a lot of things to each and everything is part of safety. So blood grouping, you should know about the blood grouping with the entity status, reservation for blood transfusion, with the patient Jehovah Witness, if there is any consent, the advance directive which is being given for the resuscitation or treatment of the patient. So these things all comes under the safety domain. So you should know about the unit protocols, new guidelines, which are the practicing clinical governance points, risk management, and duty of conduct, all these things, because these lead to the safety of a doctor, that the doctor is aware about the new treatments emerging, new evidence based researches are going on. And then important thing is the involvement of your seniors. If you are a safe doctor, you are going to involve your senior MDT team. You know your limit, what you can do and where you are going to offer. You are asked for the others to come up. Then involving the legal department when there is something comes as the Mental Capacity Act and you are not sure that you are going to involve the legal department. As I've told you, safeguarding child protection, knowing data protection, how to protect the data, when to maintain confidentiality and when to break the confidentiality. When there is an HIV patient, you have to look in the well-being of the family as well. Risk management when needed, clinical governance points, importance of documentation. This is very much important to make yourself safe and your patient safe. You have to document each and everything. So can you please just scroll? There's a little bit brief. This is central to our duty of care and has several strands to it. This includes understanding responsibilities and limitation, knowing when to seek for assistance, respecting patient confidentiality, and then you should know the Mental Capacity Act dealing with patients who are not attained the age of majority, 16 years in England, and able to understand tasks, expected, safe prescription, appropriate investigation of parents, interpretation results, and all these things. Other examples should be covered under this domain include respecting the patient's dignity, role of chaperone for initiative. This is very much important. You are going to offer a for the intimate examination, understanding and respecting religious belief, Jehovah's Witness, blood transfusion, cultural diversity, and implications for obsgyny. For example, as I've told you, fetal genital mutilation law with respect to FGM, safeguarding of children, and the confidential inquiries like embrace, the mother and baby, safe mother and baby, reducing risk, incident reporting, how to manage all these things. So, and when where there is justification to report to the GMC and be familiar with the following. Can you please just scroll it up? Our SOG and GMC guidelines, documents on consent, when and how to obtain it, what is the valid and principles of obtaining consent, have a look at the consent form in your unit. These tend to be the same nationally and available in all the units. Okay, then can you just scroll it up? Dr. Halda, can you please just move it up? And you have to know the WHO safety checklist and where it applies, safe practices, and the all as to. This is just only the example that if you are managing the trauma in a pregnant woman, if you know the protocols ABCD of the managing trauma, then this means that you are a safe doctor. And if you don't know the protocols, how you are going to manage a trauma? So for the being a safe doctor, you should be familiar with the emerging the research and the guidelines and the new material, study material which is being given to you. Just please, next slide. So other things which like I was just telling you, while if you are discussing the cases, like if you are going some hormones, as I've told you, that rule out indications, contraindications, the interactions, allergies, smear is very much important. Cervical smear history, open and honest about the risk, follow up 3 months and then annually, red flag symptoms, communication of all these things, which is very much important. And most important is this, that when you are doing any station, if you know if a question is being asked by the patient or the examiner and you don't know the answer, please don't give any false answer. This is very much annoying for the RCOG and they don't tolerate it. If you want to be a safe doctor, if you don't know anything, please accept that, apologize them, and tell them that I'm going to ask this question from my senior. I'm going to get the answer back to you after discussing with my consultant. I'm going to check on the RCOG guidelines, if there's any new emerging treatment, any new research or any evidence, and bring back and we can have another meeting. If you don't know about the drugs and the dosages, don't say wrong. Just say that I'm going to check the British formulary and I'm going to check with the pharmacy and I'm going to check with the unit protocols how it's being implemented. Don't give anything which is false, which is wrong, and you don't know. Even if the incidences come out, if the examiner is going to ask you something that what is the percentage incidence of this carcinoma, and if you don't know, just apologize simply. Just simply say it's not right now, it's not in the top of my head, but I can come back to you after having a glimpse on that information. So let me just have a look on that. So examiner will not fail you on giving you the incomplete information, but they will definitely fail you if you are going to give them a wrong information. Can you just move up for, if I just want to say if there is any other
no, this is the last
slide.
one.
Okay.
This is the last.
Okay, this finishes with the safety. There are a lot of things, but these are the main things which you should know when you are going applying on your domains. Any question? But I think the questions will be open at the end. Now I'm going giving the next domains towards the Dr. Ambreen and Dr. Fawzia. Thank you from my side.
Hello, friends. How are you feeling now?
Where is, let me check, where is your,
Yeah.
Just give me 1 minute, huh? I will.
It's okay, no problem. So I'm Dr. Ambreen. I'm your second mentor. And I think this was really very lengthy, but it is very important to revise all these things before the exam. Some of among you, maybe they are feeling that why we are going through all these things. We already know and we are doing practicing now. We are very near to the exam. But while we are practicing, we are forgetting that some important points. So we just want you to refresh your practice again so that you will not go on the wrong side. And what examiner and what RCOG exactly they want from you during the exam, please present it in front of them. So now, as Dr. Huma, she very beautifully explained about the patient safety and communication, and this is the key practice for you, that because this is very important, because a part of this you cannot pass this exam if you don't know about the safety. As Dr. Huma, she mentioned almost all the point for the patient safety that is important, and you should keep in your mind while you are doing the task in front of the examiner, in front of the role player, how you will explain your things. So me and Dr. Fawzia, we will, there are 14 domains which they need to examine you during the exam. So we will discuss one by one for each domain that what exactly they want from you from the each domain, because sometimes we are practicing but we forgot that what we need to actually need to discuss with the patient or the role play or the patient or the examiner. So my first clinical knowledge is that clinical skills. Dr. Khalda, could you please scroll down? Yeah. So in this clinical skills, what they need basically from you, that take an obstetrics and gynecological history, communicate effectively, take notes concisely and accurately, justify investigation and intervention. What does it mean? It means that whenever you are saying that I'm going to offer you for the renal function test or kidney test, so you need to tell, if you are sitting in front of the role play, you need to tell her that why I'm going to do this test, that I want to check that you need to take the correct investigation, not like any type of investigation you can offer her. Just offer those investigations which are appropriate for that particular task which was given to you, and why you want to do it, so that you will the examiner will know that if you want to do CBC, you want to know the infection or hemoglobin level or whatever, and if you want to do renal function test, do you want to see the kidney test, because why you are going to give some anesthetic medications, or she is renal failure patient or whatever. So you need to take the name of the investigation and you need to justify yourself that why you are going to offer this thing. Critically interpret the clinical findings and the result of the investigation. Again, these all domains, they are interconnected. So if these are clinical skills, they are also coming to your information gathering. This is also coming to your patient safety, that how you interpret the result and the findings in front of the role player or the your examiner. Critically discuss the management options, present a balanced view of the risk and the benefits of the intervention, making an appropriate introduction, explaining their name, role, purpose of interaction, and establishing a rapport. Taking a concise, relevant history, using a blend of many open and some closed questions. You need not to need to ask that, are you feeling pain, sharp pain? This is a closed question. It means patient can say no or yes, and then your communication with the patient will be ends up. You need to ask, could you please tell me what type of pain are you feeling now? So that she can have an open question and she can tell you what type of the pain she has exactly. Demonstrating a logical and clearly reasoned style of questioning, empathy, show empathy. You need to, now you are face to face, so now you need to show by your body texture that how you are physically, how you will show your empathy to the patient. And also you can say in your sentences that yes, I can see that you are in pain. I'm really sorry to hear that. These are all empathy, whatever the manner you can display in front of them, you should do this thing, because them don't cut their sentences, let them to speak and then acknowledge them, responding to the patient cues. Identify and managing the communication barriers, including the use of interpreters. If any case, like FGM, there is a patient that they are mostly coming from the Kenya or the Ghana or somewhere else, then you need to, if they are saying that the patient is coming from the Ghana or she's from the India, or this is your this is also your patient safety, that you need to ask that, do you want any interpreter or translator with me so that I can communicate with you. This is, it also comes in patient safety, and they have their mark. So never ever forget about this thing. Giving information in manageable amount, using the patient friendly language, like you need to read, you have to read, all of you, patient information leaflet, so that you can have the patient friendly language. They don't like medical jargons, they don't and they will not give you the marks. Avoiding jargons and explain the clinical terms. encourage dialogues and shared decision making, negotiating skills, but demonstrating the respect to the patient and autonomy in decision making, including there are certain cases where the patient is demanding, the task is coming to, yet this patient want this, like let us say that twin patient, and she's asking for the normal vaginal delivery, and it is not possible for her, or she wants home delivery. So here you need to give her all the information, the good and the bad one, but you not need to compel her to go and deliver in the hospital. You will give all information and just maintain patient autonomy and respect her wishes, and give her next appointment to your consultant so that she can make the good decision for herself. And this is also comes in the patient safety points. Next slide, please. Next slide. Yeah. Acknowledging and addressing the patient concerns, taking informed consent, including an awareness of the mental capacity. This is also very important, that the age of the patient, or they are Alzheimer's disease, or they are elderly patient that they cannot understand. So you have to be very careful, and you should know that how and when and how to take this consent from these people. Maintaining patient dignity all the time, ensuring appropriate use of chaperone for the intimate examination, maintaining dignity at all time, and being sensitive to the culture and the religious issues. Next slide, please. So the second thing is that we are going to discuss about it is teaching and the research. It is understanding the principles of adult learning, demonstrate the aptitude in the teaching common practical procedures in the OB-GYN, and understand the quality improvement and the management. They can ask you anything now. This is the face-to-face examination. Now they can bring anything to you. So be careful. You should know all the things, clinical point of view, and those things which are practical point of view. So understand how to perform, interpret, and use the clinical audit cycle, understanding the production and the application of the clinical standards, guidelines, and care pathway and the protocols. Demonstrate a working knowledge of the principles of the risk management and their relation to the clinical governance and compliance procedure. Understand the difference between the audit and the research. This is one of the tasks for them, and this is very favorite topic for them. So you should understand the difference between the audit and the research. Understand how to plan a research project, demonstrate the skills needed to critically appraise the scientific trials and the literature, understanding the principles and the legal issues surrounding the informed consent with the particular awareness of the implication of unborn child, postpartum examination, consent to the surgical procedures, including sterilization, parental consents, and the Fraser guidelines, medical certifications, research, and the teaching. Demonstrate awareness of the relevant strategies to ensure the confidentiality, and when it might be broken, understandable to the role of the interpreters and the patient advocates. Next slide, please. Next slide, please. So now we are coming to the third area, that is core surgical skills. And over here, we need to discuss about demonstrate. Could you please go to the next slide? Yeah. So demonstrate and understanding here the core surgical skill. When you are sitting in the this module, you need to know that the issues surrounding informed consent, because sometimes they are giving you the task for the consent. Sometimes the consent is already taken and the patient is changing her consent form. Then you should know that whom and how to contact with your consultant, and where and how much you can go for this, and including the knowledge of the complications rate, risk, and likely success rate of the difference. So all the consents form you need to learn by heart, because they can ask you anything now, together with an understanding of diagnostic methods and the treatment of the complication. Demonstrate your familiarity with the surgery by discussing the common operations together with the common surgical instruments and suture. They can bring any any procedure with along with the instruments, and this is the structured discussion, and they can ask you to during while you are explaining the procedure, you need to pick up the instruments, and you need to pick the instrument very rightly in a medical in a systematic manner, that where your thumb should be and where your index finger, and how you will pick the instrument. They will note all these things, so you should be very careful on these things. Demonstrate detailed knowledge of the basic surgical procedures in the OBGYN, and including the diagnostic laparoscopy, hysteroscopy, gynecological laparotomy for the ovarian cyst, ectopic pregnancy, hysterectomy, vaginal surgeries for the prolapse, incontinence, and vaginal hysterectomies. Know the principle and the procedures involved in the more complex gynecological surgeries for cancer and the endometriosis, because you need to explain to the role player what are the implications and what extent she can go. You need to tell, and you need to be very honest to the patient, and whatever she will ask, you will not hide anything from that patient. This is the patient right to know about it. Have good knowledge of the print, and if you don't know, just say that I'm sorry, I will come back to you. I go back to literature, and I will come back to you shortly. Have good knowledge of the principles of the safe surgery, surgical instruments and sutures, and the management of the common complications of the surgery. Be aware of the principles of the surgical teamwork, risk management, and the risk reduction. This is enhanced recovery program. You need to read all briefly so that you will know all these things. Next slide, please. So now the fourth knowledge area is post-operative care. Here we are expecting from you that you should know about next slide, please. Demonstrate an understanding of the aspects of post-operative care, immediate, short-term, and long-term. They can ask for any patient in like any immediate complication, intraoperative, post-operative, right after the operation, or 4 hour the operation, or it could be the 24-hour the operation. So you should know the difference, or they can come within the 4 days of the operation. So you should know that what complication could be happen within hours to the days, and according to that situation, how you need to handle it, including the ability to assess a post-operative patient, know the diagnosis, and know how to deal with it. Know how to prevent common post-operative problems. Sorry? Hello? Be able to discuss all the aspects of surgery, complications, and follow up with the patient. You should know exactly some most common cases where you need to know that when and how to call the patient, whether it is the 4 weeks or the 6 weeks, you need to call the patient, and to whom to call to the patient, and relative detailed knowledge requirement. Knowledge of the NHS improvement program, enhanced recovery principles to enhance patient safety and ensure the patient experience optimal post-operative rehabilitation. General pathological principles of the post-operative care, post-operative complications related to obstetric, gynecological, and non-gynecological procedures, fluid electrolyte balance, wound healing, late post-operative complications, including secondary hemorrhage. Next slide, please. So now the fifth knowledge area is antenatal care. Here we need to, they need from you to know about having a high level of, could you please scroll up? Yeah, having a high level of understanding of normal antenatal process and the progress. Be able to recognize and manage the problem from the pre-conceptual care through to the delivery. So this is a very important module for you all people, and you need to be very careful while you are demonstrating this in front of your role player or the examiner. Be able to deal with the diversity of the maternal choice in antenatal and intrapartum care. As I mentioned already, that patient can ask you anything, and you need to be not judgmental, you need to be very neutral, and you need to give her all the informed decision so that she can make the informed decision, and you will respect the autonomy. You will not say that this is a good, not the right decision. You cannot say this thing. Whatever she will say, you just appreciate her and just give her information and give her some information leaflet. And this is the patient right, that she can choose whatever it is she think that it is suitable for her. Demonstrate the skills in listening and in conveying the complex information, showing understanding of the roles of other professions, like multidisciplinary team you need to include in it, and demonstrate the skills in liaison and the empathetic teamwork. Be fully conservant with the principles of the prenatal diagnosis and the screening. You should know about like Down syndrome screening, and they are coming and they are asking you. So you should have a full hold on this topic, so that whatever they will ask, in whatever they expect they will ask, you should know about all these things. Understand the ways in which the problems may affect the fetus, and be able to interpret and act upon any appropriate investigation information concerning the risk for that particular case. So the next is the maternal medicine. With regards to that, we need to able to describe the natural history of the disease and illness. So this is the difference between the antenatal module and the maternal medicine, that you need to tell the natural history of that disease and illness that runs the chronic course, having the knowledge of the long-term management plan for the chronic condition, understand the epidemiology, etiology, pathophysiology, clinical characteristics, and the prognostic features and the management of the hypertension, and other things, definition, etiology, theories, organ involvement, mother, feeder, diagnosis, drug therapy. You need to discuss all these things, the effect of the disease on the mother and on the fetus, and the effect of the disease on the pregnancy, and the effect of the pregnancy on that disease. You need to discuss with the patient. You also need to tell her that what could be happen to her during the pregnancy, and what could be what happened to the fetus. You need to be very honest, and you need to tell all the information to the patient. And you need to also discuss about the medication, what kind of medication she is taking, that it is very important. Then understanding the epidemiology, etiology, physiology of the clinical characteristics, prognostic features, and the management of psychiatric disorders, manic depressions disorders, psychoneurosis, behavioral disorders, blues, depressions, mood disorders, schizophrenia, reaction to the pregnancy loss. Understand the epidemiology of the pathophysiological clinical characteristics, like hemoglobinopathies, anemia, sickle cell disease, thalassemia. You also need to know about all the chronic disease like SLE and rheumatoid arthritis, immunology, type 1, type 2 diabetes. These are all diseases that you should know. They can ask you anything. They can bring anything to you. Ketoacidosis, drug, insulin, hypoglycemia agent, pregnancy, and abdominal pain, appendicitis, inflammatory bowel disease, intestinal obstructions, neoplasia, principles of the pregnancy. They can ask you anything. Next slide, please. So the 7th area is management of labor. Here we need to, what they want from you to know is, would you please scroll it up? So here they need that you should know and have the knowledge and skills, understanding and judgment to be capable of initiate management of intrapartum problems without direct supervision, including the knowledge and the understanding of normal and abnormal labor, data and investigation interpretation, clinical judgment and prioritization, management of the team, communication skills, insight and knowing one limits, emotional and cultural awareness. Emotional means here that if the patient is in pain, you need to stop and you need to give her some time and then take permission again and then talk with her and start further management. An appropriate use of protocols and guidelines, mechanism of normal labor and delivery. It can come as a teaching, induction and documentation of the labor. It is just come in the as a role player, drug acting upon the myometrium structures and the use of the partogram. It can come as a teaching, and the fluid balance in labor, blood products, regional anesthesia, analgesia. Patient can ask you anything about that, prolonged labor. Next slide, please. Next slide. Then the last but not the least, emergency policies, maternal collapse, hemorrhage, preterm labor, premature rupture of membrane, cervical cerclage, multiple pregnancies, in labor, severe preeclampsia and eclampsia, in utero fetal death, including legal issues, acute abdominal pain, mechanism of normal and abnormal labor, mechanism of spontaneous vaginal delivery, method of induction of labor, induction, contraindications, complications, method of augmentation of labor, indication, contraindications, and complications. You see, whatever they're asking the whole thing. They are not asking that you will just tell the patient that I'm going to give you the, I will do the rupture the membrane. You need to tell why I'm going to rupture the membrane, why I cannot rupture your membrane, why what could be happen, cord prolapse or anything else. You need to tell her all these things. They want not only the action, they also want from you that you need to justify whatever the actions you are taking for her. Drugs acting upon the myometrium and the cervix structures, and the use of partogram, and fluid balance in the labor and transfusion. I know it is very lengthy, but you should know all these things, what they want from you, so that you can better plan for your exam, so that you know that whatever information I'm giving to the role player or the examiner, it is appropriate, and I have given fulfill the all tasks so that you will be satisfied with yourself. So plan your practice with your partner along with all these lines, so that you will know that you are not missing anything what they want. Now this is from my side. Now I'm giving to handing over to the Dr. Fawzia, so that she will continue for the next 7 domains. Thank you so much. Whatever the
Okay.
questions you need to ask, just you can ask in the end. Thank you.
Okay, thank you very much, Dr. Ambreen. Can you all of you hear me?
Yes, yes.
Okay, already Dr. Huma and Dr. Ambreen has explained so many things. I'm just following them now because you are appearing in November, so I know that you know everything. But we are giving, just refreshing your knowledge, as Dr. Ambreen told you. Can you change the slide, please? Okay, so next knowledge area is the management of delivery. What you have to demonstrate in this, you have to demonstrate certain aspects of practical skills. They can give you a dummy, there will be pelvis, there will be baby. They may ask you to do the normal vaginal delivery. At that time, you have to perform, and then you have to tell the prerequisite, how you will perform, and how after delivery, what you will check, and what are the possible complications. It may come as a SD, it may come as SPT, it came as a teaching. It may involve a normal vaginal delivery. They can ask you the steps, operative vaginal delivery, complex vaginal delivery, retained placenta, and all of these management of female genital mutilation, how you will manage the labor in such cases, malpresentation if came in labor, what you will do, how it became as SPT most of the time, malpositions, manual rotation of the fetal head, outlet forceps and mid cavity forceps, ventouse, rotation, when they are used. As I told you, you have to finish all the things, and you have to perform sometimes pelvic floor anatomy, physiotherapy, perineal trauma and repair, and where you have to involve your consultant, and what you can do, and where you have to involve them. Female genital mutilation, whether you will do, what you will do, and how you will proceed. You should know the things, assisted breech delivery, undiagnosed beach game, what you have to do. So it involves it start from the information gathering, then it patient safety point came everywhere, and then it will come to the how you perform the procedure, and in the prerequisite procedure and the postpartum, all it will come. And when you have to involve the clinical governance team, what you have to write your 3D. Now next is the postpartum problems. Next, please. You have to demonstrate similarly appropriate knowledge, skills, and attitudes in relation to the postpartum problems, including dealing with the resuscitation of both the mother and the baby, and the ability to manage birth trauma and other birth complications. You have to show your empathy, counseling skills if she has any problem, like if she has any instrumental delivery and later on she has third degree perineal tear, then you have to be empathetic. If maybe she is angry, so you know how to deal with her, understand, be able to manage neonatal problems and birth, and be able to discuss these with the parents. Detailed knowledge required normal and abnormal postpartum period. Techniques for the control of postpartum hemorrhage, all of you, appropriate use of blood and blood products, manual removal of placenta, bimanual operation. These are all the steps: exploration of genital tract, cervical laceration, tract management, how medical treatment, and then the surgical management, including balloon, laparotomy, and all these. Repair of episiotomy, second, third, fourth degree laceration, retained placenta, postpartum and post-operative complications all came in this one. Epidemiology, etiology, pathogenesis, recognition, diagnosis, prevention, preventive measures, complications, prognosis regarding uterine involution, bleeding, including placenta accreta, atonic uterus, retained placenta. When patient came with the APH or PPH, you should have in your mind everything. Retained product of conception, pyrexia, infections, maternal collapse, include massive hemorrhage, cardiac problems, pulmonary and amniotic embolism, drug reactions, trauma, thromboembolism, lactation, inadequate suppression, medical disorders, diabetes mellitus, renal disease, cardiac disease, what you will do in the postpartum period, postnatal review, contraception. These are all, all of you knows, but it's just for your refreshment. Postpartum and postoperative complications, including pathophysiology, diagnosis, management, and prognosis in peripheral psychological disorders, blues, depression. You should know when blues and what are the signs of depression, what are the medications, mood disorders, reactions to pregnancy loss, peripheral sepsis, mastitis, urinary tract infections. These are all common problems. Okay, now coming to the gynecological problems. Next, please. You have to demonstrate again you should know the etiology, sign and symptom, investigation and treatment of common gynecological problems, appreciate the influence of social factors on the presentation and management of gynecological problems using a patient-centered approach. Demonstrate again all the things came in what each module. You have to start with information gathering, patient safety, communications, then investigations. Please, last slide, because I didn't finish yet. Last slide, please. So demonstrate your understanding of the importance of audit, clinical governance, and taking informed consent to understand the epidemiology, etiology, biological behavior, and pathophysiology, and also the prognostic factors and management of pediatric gynecology, able to describe the natural history of the disease and illnesses that run a chronic cause, having knowledge of the long-term management plan for chronic conditions, able to demonstrate the anatomy and physiology of the vulva, to demonstrate the biological behavior, pathophysiology, and prognostic factors and management of menstrual disorders, menstrual irregularities, excessive menstrual loss. You have to demonstrate what is menorrhagia. You should know what is abnormal uterine bleeding, when you have to do the biopsy. And next slide. Next, the next is the self-fertility. Okay, self-fertility is also very important, and you have to be very empathetic when you are taking information gathering, because these patients are very sensitive. So you should know how to deal with them. You should have a broad-based knowledge what investigations she has done. You have to ask specifically, and what you are going to do if you are giving her advice regarding the assisted reproductive technologies. You have to have a very vast knowledge. You should know what ovulation induction, whether patient knows IVF and ICSI and gamete donation and surrogacy, the legal and ethical implication of all these procedures, and you should know how the prognosis of male and female fertility. And last one. And indications and recognition, limitation and complications of surgery in relation to male and female fertility, like endometriosis, developmental disorders, indications, limitation, and complications of ARTs technology. Next, please. You have to be competent in in having a knowledge of long-term management plans for chronic conditions. Especially subfertility is a painstaking and sometimes it takes a long time. So you have to be very empathetic and very sensitive with the patient's emotions. Ovulatory disorders, you should have a detailed knowledge of tubal disorders, endometriosis, and cervical and uterine factors, how the genetic and developmental disorders will affect the fertility of the patients, and how endocrine, pharmacological, infections, lifestyle, genetic will affect her fertility. You have to be very much knowledge of how to manage all these things. But as I told you that you should be very empathetic and sensitive with these patients. Knowledge area 12 is sexual and reproductive health. Next, please. You have to demonstrate appropriate knowledge, skills, and attitude in relation to the fertility control, the diagnosis and management of sexually transmitted infections, how STDs are going to affect the fertility. You have to be very much familiar with this and how you are going to explain to the patient, especially young patient. Be familiar with the irreversible and emergency contraception, their abortions, their modes of actions, indications, contraindications, complications, and laws relating to the abortion and STDs, consent and child protection. You have to be broad-based recognition of management techniques relating to the sexual health of vulnerable groups such as young people, asylum seekers, commercial sex workers. These are very sensitive, and you have to be these all came in communications, how to deal with these type of sensitive patients. You know that you should know the basics of national screening program, how they will be implemented, reversible, irreversible, and emergency contraception, how termination of pregnancy, and also can you show me the last one? Thank you. And also the reversible image and the laws relating to the termination of pregnancy, sexually transmitted infection, child protection, and management of sexual health care needs of vulnerable group, and recall the effects of addictive and self-harming behaviors, sexually transmitted, including HIV, AIDS transmission, clinical features, management transmission. In this, in sexually, this one, sexual health, sexual and reproductive health, you have to be very careful that you should provide enough support to the patient. You should know that these type of patients are also very vulnerable. Now came the 13 area, early pregnancy care. Can you move on? You all know what are the problems can occur in early pregnancy and even early pregnancy loss. You should know the diagnosis, investigations, management, and psychological support in miscarriage and ectopic pregnancy. Be able to assess and manage these conditions both medically and surgically. Demonstrate your ability to communicate relevant information to the patient. Have knowledge of the use of ultrasound in diagnosis and management. Detailed knowledge requirements, etiology, pathogenesis, and last one, please. And clinical features of miscarriage, trophoblastic disease, and ectopic pregnancy. These are very important, and these are sometimes they came with recurrent. So you should know the whole management, medical management of ectopic pregnancy, where it is contraindicated, where it is indicated, indications and limitations of investigations, endocrine, anatomical, and radiological, understanding of management options, prognosis after miscarriage and ectopic pregnancy, because patient can ask you anything, even your examiner can ask anything. Next, please. The last one is gynecological oncology. You should have a full knowledge of the etiology and screening involved in gynecological oncology. So family history is very important. Understand presenting symptoms, because symptoms are usually vague, their management, and have the appropriate competencies for each stage of the diagnostic process, including comprehension of the different roles and skills needed in district lead and gynae oncologist. Know the prognosis of and treatment options for gynecological cancers. Be able to demonstrate your ability to provide counseling for patients with gynecological cancer. Detailed knowledge requirements is, again, here patient communication is very, very important. You should know what kind of words you have to use. Either it is BBN, maybe it is diagnosed case, she came with a recurrence. So you have to be very, very empathetic. You should ask her about the support. maybe her sister's or patient sister or patient daughter will come. So you should know the genetic associations, how to diagnose, how to prevent, screening, management, complications, and ethical considerations of the pre-malignant and malignant conditions of vulva, vagina, uterus, cervix, fallopian tube, ovary. FIGO classification, you should all know. Palliative and terminal care, you should all know. How to relieve symptoms, community support, roles are very important indications. And sometimes financial support, they may be alone and they don't have anyone to earn for them. So you have to be very along with the moral support, they may need financial support also. Indications and limitations in relation to screening and investigations technique, when the HPV screening are started, in whom started, in school, at what age, and how to consult the mothers or the girls. Diagnostic imaging, indications, technique, complications, and outcome of oncological surgery, radiotherapy, chemotherapy, MDT involvement, when you have to refer to the specialized oncology centers, awareness of HPV vaccination, knowledge of gynecology, oncology, MDT. Thank you very much. Good luck from my side. And I think it is just a revision, and you have only 10 minutes in which you have to complete your station. Now, Dr. Khalda and Dr. Zubia will continue and just practice and now I will switch over to the Dr. Khalda. Thank you for listening. Dr. Khalda?
Hello.
Yes, Dr. Khalda, please take over.
Hello, just 1 minute. Give me, I will share the slide, okay? My slides are being seen. You can see my slides?
Yes, station 2, yes, we can see.
Yeah. So, who is going to do the first station with me? Before starting first station, I want to give you a few important hints regarding your face-to-face exam, because this is what we learned when we were going for the exam, although we did not enter into a face-to-face exam. But when we were there, we were told that when you are going for a face-to-face exam, your overall impression begins when you enter into the cubicle. And before entering into the cubicle, all of you know that once you finish your task, there will be a bell will ring. You will move, get out of because once that bell rings, it means your next 2 minutes for the next task starts. So when 2 minutes for the next task, it means you stop whatever you speak there. Just quickly say thank you for speaking to me, to your role player, and quickly come out of the cubicle and move to your next cubicle, where on the wall there will be there will be some paste on the wall. The task will be pasted along with. Usually, you will have multiple papers. In some tasks, you will have multiple papers. And believe me, it's not easy, and it's inhuman to assess and to read and to go through all those papers in 2 minutes. But these papers are also available inside the cubicle on your table. So if we start from beginning, that if you are entering into your first cubicle, when you are going into your first cubicle, when you enter into the cubicle, the impressions start when you walk into the cubicle. And this impression of your personality start from your dressing. It start from your face expression. It starts with your gait, how confident you are. These all are being assessed by an examiner, which is usually sitting at the corner of the cubicle, but observing each and everything. So from my side, this is important advice that when you are going for exam, have a well-dressed and a decent dressing. According to your culture, it doesn't make the difference, but have a decent and a doctor-looking dressing. This is one thing. Have a good facial impression, not in a state that you are confused and you are very anxious and you are very you are not in your don't show to the examiner that you are being your nerves are being affected by this exam. No, you should enter in a very confident way, in a very calm way, to the cubicle, say whatever the time it is good morning or good afternoon, whatever the time you are appearing in the exam, say good morning and good afternoon. And when you enter into cubicle, if your patient is emergency, then immediately you will manage your patient. Emergency patient, you know how to deal with. Along with your dressing and your entering, you will be provided with one pencil and you will be provided with one note-taking pad. And that is your job, and that one pencil and one notepad will be provided to you, and that you have to carry on with you for the 14 task. Nobody is there to take it with you. So what happens that during the exam, the candidate get confused, they are not happy, the role player is playing around with them, and they get confused and they forget their pencil and their notepad in the cubicle, and now they don't have pencil and notepad for the next station. So this is very, very important advice to all of you, because you are going for face-to-face exam. The most precious thing in your exam will be your notepad and your pencil, and because with that you will take the notes, and I would suggest you to write down your patient name on that notepad, and I would suggest you to write down the age of the patient. And when you are entering into the cubicle in the last moment, last few seconds, 4-5 seconds, when the bell is about to ring or when the bell is ringing, quickly go through your patient name and her age, so that inside when you go to the cubicle, because sometimes the candidates are so confused that even the patient tell the names, you forget it, or you confuse it with your previous station patient, so you take the wrong name, and this put not a good impression. So your overall impression begins, and your passing of the station begins from the time you enter into the cubicle, and your first 1 to 2 minutes, the examiner decide about what he has to do with you. Because they are also examiners, they are human beings, they are continuously listening to all the candidates. What they are listening to all the station attentively, and it's your job to perform your station perfectly. But beginning and ending of the station is the time where you have to be very confident. Now, it's important, remember this point, that take your notepad and your pencil with every cubicle with you. And if you are interested in writing something, the role player is telling you, just take a permission, because this is ethical that you will take the permission and write down those notes. If you without taking the permission, you start writing note, it's considered as unethical, because you are recording her statement. So you should inform her, take her permission, and then start writing if you want to write. Then initially, have eye-to-eye contact with your role player in the beginning, and don't be afraid from your role player. They are human beings, and they are trained to take you to that path of the station where the marks lie. So just listen to them very attentively. Not only listen to them, have an overall impression of their face as well, that whether they are happy, they are not happy, how they are behaving, whether they are irritated. If they are irritating, your nerves at the back of your mind should continuously work, where I am wrong, what she wants from me. You should think about it and go other way. Now, once you will talk to your patient, ending of the station, it's very important that do you have any question for me, and thank you for speaking with me. These should be your ending lines always, because try to finish your task in 9.5 minutes, so that you have 30 seconds to ask the role player, does she have any more questions? And also ask the role player, does she have any more? And thanks her at the end. Now, once you come out of one cubicle, you will go to other cubicle with your pen and notepad, and then you will read there the material. Leave behind what has been done. Now you are in a new scenario with a new mind. Go to that scenario, apply your mind on that, pick important points, and go to your next station. Believe me, the people are saying, and we have all been through, and maybe some of you have gone through this exam. These are the most precious. These are the most fastest time in your life. You will go through, run through 14 tasks, and you will never know. And then at the end, you will come to know, yeah, I finished my task. This is the fastest time in your life. So, but utilize it. It is the exam of the nerves, those who have their control on their nerves, those who have the good preparation, those who are in a good practice. There is no issue that the examiner will fail you. You have to be confident. You have to know, practice more and more. This is now the two crucial months. September and October are the two crucial months for you people to practice, practice, and practice. Practice will improve your timings. Practice will improve what you have to speak in a station. And the last point from my point of view is that it's important because the college likes the recent things. So it's important that you go through the recent talks. At least if you cannot go through all the talk throughout this detailed talk, you should go through the tables of the talk articles which are recently being published. Because like I will give you an example, like postcoital bleeding is a recent talk, like peripartum cardiomyopathy is a recent talk, a very recent talk about the acute coronary syndrome. Now, if someone has not gone through that talk, acute coronary syndrome talk, and if the station comes, there is no need to worry. Just, take it as a station of maternal medicine. And all of you know what you have to do with a cardiac patient. You have to assess her. You have to ask her, classify her NEHA classification. And then you know what investigation she needs. You know what pre-pregnancy counseling she needs, what medication need to be stopped, what dose of folic acid she need to take, what is the what medication. You have to refer her to her specialty doctor before getting pregnant to have opinion whether she is eligible to get pregnant or not. Offer her pre-pregnancy counseling, what investigation need to be done. And then if she get pregnant, go trimester wise, that what she need in first trimester, what you will do in second trimester, what in the third trimester, what time you're going to plan her delivery, what is the method of delivery, mode of delivery, and where she has to deliver, MDT involvement, then postpartum, the breastfeeding, the contraception, refer back again to the doctor, her doctor, and medication. What medication, if change in the early in the pre-pregnancy, need to be restarted again. So even if you don't know the station, this is something which all of you know how to deal with the maternal medicine station. So there is no need to confuse about that. Just go through your routine stations and you will be able to do it. It's not that difficult. Then this is all about a few points. And yeah, somebody asked that they will provide you the notepad and the pen. Yeah, they will provide you a pencil. I think they are providing the pencil or a pen, but a notepad which you have to carry. Because when we were preparing for the exam, the mentor told us that what the candidate in the confusion state, they forget it, and then they don't have it to carry on it to the next cubicle or to the next task. So be careful about that. Be in your nerves. What will happen, that will happen. What has been done, what you have done, what you have preparation done, that has been done. Now you have to move ahead. So I think it's a long time. We will start with this brief advice from me, and we will start the new station, the station. So who want to present the first station? Please unmute yourself. This is the structured discussion task. You cannot see my table. Let me check again. You cannot see my slide? Let me check. I think I have to stop the recording and then share again. There is some issue with that. Just give me 10 minutes. Huh? I will share with you. Just give me 2 minutes. We will keep 2 minutes, and I will give you the scenario and then after that 10 minutes, okay? Please open your mic. Who is going to start? Anam, you want to do? Who want to do? Please come forward. Who want to do station? Who want to do the station? Please unmute yourself.
Noreen,
Sorry.
Noreen, Huma,
Who want to do?
come
The
forward,
Abdullah
my
was
dear.
telling I want to do, then Rekha was telling, where are they?
Anam, Aisha,
Abdullah want to do. Abdullah said I want to do. I said okay. Rekha, you want to do? Just do it. Why you are afraid of structured discussion? Nothing. You will learn something. If you are, please come forward. Who want to do the station?
I can do Dr. Khalda, but my net is very weak and I'm in the hospital. So there would be a lot of disruption.
Sorry, ma'am, I was busy in the case. Sorry. I will do.
Okay. Rekha, you want to do?
Yeah.
Okay.
Yeah.
So come forward. I will give you 2-minute time to read the scenario and then you can go for that.
Mm-hmm.
So let me keep your 2 minutes time.
Can you show me the scenario, please?
Yeah, I will show. You can see it. Your time starts now.
Any other slide?
No, this is all about. Yeah, these are the questions. So we can start.
No, wait 1 minute, ma'am.
Okay. Organize yourself. We will start. Your time finishes. So start now. Start.
Okay, so I'm Dr. Rekha. I read the scenario. I'm ready for structured discussion.
So how is your exam going on, Rekha?
Yeah, fine.
Okay. So you have a lady who has been 32 years old, Abigail Smith, and she has only one smear, and now she presented to you with a postcoital bleeding. So in your clinic, so what information you are going to take from her further?
I would like to know that further information in the form of the history examination and investigations. So I would like to know that why she did not attend her previous smears, and
Mhm.
for how long she is experiencing the postcoital bleeding, and
Mhm.
what's the amount, and any
Mhm.
other associated symptoms like any dyspareunia and any vaginal discharge, lower abdominal pain, any weight loss, appetite loss, to rule out any cancerous changes she is having. And rather, this is the first episode she is experiencing. And what's the age of the patient? She's 32 years old. And then, if her previous smears report, what's that report shows, I would like to know. And then I would like to know that the how many she's only using any contraception, and what about her what medications she has tried, and any other investigations done so far. And I would like to ask about her sexual history, and then how many partners she is having, any multiple sexual partners in the past, because it can increase the risk of the cervical cancer, and any STD in the past. And then I would like to know that how many babies she is having, and what's the mode of the delivery, and any complications she faced at that time, and any health issues she is having, like diabetes, hypertension, any surgeries in the past, and any medication she is taking, any allergies. And other than this, I will what that she smoke, patient smoke, drink alcohol,
Please
because
unmute,
smoking is one
mute
of the
your mic.
factor to increase the cervical cancer, and alcohol, any recreational drugs she is having using, and what she does do for her living, and what about the support at home, and then what's her BMI. And then I would like to examine the patient. Sorry.
Okay.
Okay, so then I would like to examine in the presence of chaperone, by taking her consent. I would like to check her BMI, because if the postcoital bleeding is one of the factor for the cervical cancer, so any cachextic signs, any muscle loss, and do her abdominal and check her general health by checking the blood pressure, pulse, temperature, respiratory rate, and abdominal examination to rule out any mass, and they do the vaginal per speculum examination to see any changes in the cervix, and any growth, and because the polyp and any ectropion could be the reason behind the postcoital bleeding. I would like to rule out that, and the size of the uterus, and if any discharge, I will take the swab at the same time to rule out the STD, because it could be the factor of for that. And then if the patient is not allowing for the examination, then the further examination will be arranged in the examination under the anesthesia. And I would like to do the further investigations, like the first of all, I would like to check her cervical smears, and
Mhm.
I will arrange the colposcopy to see the so that I have an idea that what are the changes in the cervix are there, and
Okay.
then
Okay. Can you tell me
complete
what are
blood
the
count,
risk
renal
factors
function
for
test, liver
cervical
function
cancer?
test. What are the risk factors? Can
Yeah.
you show me the first slide, please? Yeah, cervical cancer risk are the if the patient is multiparity, and the STD in the past, and multiple sexual partners, and earlier age of the intercourse, um, and if she is not attending the cervical screening program, and smoking. So yeah, these are the risk factors.
Okay. Now, next, what investigation? Just tell me overall what investigation you are going to offer to this patient, and the one which are
Yeah, I
going to
will
help you
do
in
the
staging of cervical
complete blood
cancer.
count, renal function test, liver function test as a baseline, and the also
Okay.
the MRI, because it could give me an idea about the extent of the cancer. And yeah, further, yeah, this is all I do. And the colposcopy, of course.
Okay. So your patient has been diagnosed with stage 1B1 cancer of cervix, and
Mhm.
how you are going to manage her in oncology center as you want to preserve her fertility.
Yeah, so as she is a stage 1B1, so up till the stage 1B1, we can offer her the option of the trachelectomy. So I will
Mhm.
discuss with her, but before that, I would going to involve my consultant also and take the opinion of the cancer specialist doctors. And I can offer her the option of the trachelectomy, but I will discuss the pros and the cons of the option. That if she go for the trachelectomy, it can preserve the uterus, but it can increase the risk of the complications in the if she get pregnant, like the miscarriage and the preterm labor and cervical insufficiency. So all the complications I will discuss with the patient.
Okay. Now your patient trachelectomy has been done, and now she is pregnant in first trimester, around 11 weeks or 10 weeks. How you're going to take her care in this pregnancy?
Having the trachelectomy makes the patient high risk. I will manage in the consultant-led unit under the team of the specialist MDD. My consultant will be involved, counselors, support groups, and they also the specialist nurse midwife. And I will going to offer, because the trachelectomy can increase the risk of the infection. So infections screening will be done from the 16 weeks onward. And if there are any signs of the infection, then I will provide her the prophylactic antibiotic. And they also I will counsel the patient that there is a risk of the preterm labor. So cervical insufficiency will be checked by means of the transvaginal ultrasound. Scans will be done for the cervical length. And I will counsel regarding the avoiding of the sexual intercourse. And the also from the, if there are any signs of the preterm labor, I will give her the prophylactic steroid cover from the 24 weeks onward. Discussion will be done.
Mhm.
At the I will the frequent scans will be done. And also the I will do the elective cesarean section at the 37 weeks, because I will not allow the patient for the vaginal delivery, because it can increase the risk of the rupture. Because as the cervix is totally obstruct, so I will do the elective cesarean section with the classical cesarean section. 37 weeks planned cesarean section will be done, and afterwards I will discuss the contraception with the patient for at least 6 months after the procedure. And regarding the IUCD will be difficult to insert, so coils and Mirena coil and the IUCD will not be a good option. And the
Mhm.
progesterone only pills also affect, as they work by the cervical mucus alteration, so it is not there. So better option is to go choose the other contraception apart from the progesterone only pills and the IUCD. And I will discuss the plan of the delivery with the patient, and the patient's concerns will be addressed. I will give the patient information leaflet and the document in my notes, and also going to involve my consultant regarding this all. And the patient will be provided with the support and this all. And also I will document in my notes and connect with the counselors and support group.
Okay. Anything if you
I
want to
did
add in
a long
any of the
time ago.
question?
Thank you so much for your time.
Thank you. How was it?
Dr. Khalda, I did cervical cancer very quite long time ago, and trachelectomy, I don't know.
Actually, I made this station like this because postcoital bleeding is a very recent talk, and it's a very ideal task for a task to be given in part 3 exam. And the tables are very
Yeah, I read
important.
it, but quite long ago, so I don't know what I am saying
Today
at
you
that
will
time.
revise. So today you will
Yeah,
revise
yeah,
and you will know.
yeah.
Your approach is okay. I will say okay. This would be while doing the structured discussion. I hope so. After studying this talk, you will be more organized. More. You will be like you were talking. Your answers were to me were like general answers, like generally like the background knowledge which you have. You were answering on that. But if you have a very recent knowledge, then it means this knowledge will be
Beneficial, of course.
yeah, it will be beneficial, and you will talk to the examiner in a very structured way and organized way. And it doesn't, the examiner will feel like, I feel that you are answering me generally. Maybe you have not gone through it very recently. And if you
Yeah,
know it, the
yeah.
examiner can assess that she have gone through this material and she knows about it.
Yeah.
Your information, your answer to the first question was around nearby 5 minutes, and I interrupted you because I want you to complete all these questions. So
Yeah, you're right.
be careful about, and you know how it will come. It will only come through the practice. That it will come through the practice. You will practice with your role player. This postcoital bleeding talk is one of the important talk. Just sit with your role player and practice it. Now, the answer to
Mhm.
the first question is that you will go to the thorough, you will say that I will take a thorough history from a patient and I will examine to elicit any risk factor and any signs which are suggestive of underlying pathology. This can be a CA cancer, it can be just cervical erosion, it can be just cervicitis as well. You never know. So I will ask about the patient age has been provided to me as 32 years. I would like to know further about postcoital bleeding in terms of duration, frequency, and the amount of the bleeding, whether she is using any pad, and if using, how much she need to change. I would like to know about her menstrual history, past menstrual history, including whether she has any normal bleeding pattern or any abnormal bleeding pattern, and what was her last menstrual period date. The presence of other symptom, as you told, vaginal discharge, pelvic pain, dyspareunia. I would like to know about her contraceptive history, because sometime hormone replacement, tamoxifen therapy, any
Yeah,
medication.
I mentioned
uh,
contraception.
yeah, and history of HPV vaccination is important.
Yeah,
Whether
I do.
she has gone through HPV vaccination, cervical screening history, including date, and as she has not been undergone
Yes.
8 year, you rightly said that what is the reason behind that. Detail of any previous colposcopy, any treatment, sexual history, history of multiple sexual transmit, sexual partner, and any STI, and history of any STIs, past medical and surgical history, any bleeding disorder. This could be due to any bleeding disorder. She may have some,
Mhm.
in our practice, we have a patient with von Willebrand disease, and she was repeatedly being admitted to the hospital with intraperitoneal bleeding. And when they investigated, they found that she has von Willebrand disease. So always in a patient with a bleeding disorder, always ask in the history with a bleeding problem, any bleeding disorder, any medication,
Mm.
like if she is using any anticoagulant, maybe she is some heart patient, she is using warfarin, maybe she has taken a high dose. So all those keep in point the bleeding, and then arrange your history. Other risk factors such as smoking status, her age of first coitus, her smoking, any family history. Family history is very important.
Ma'am, I
Any
did not
cancer.
ask about the family history because the cervical cancer is not inherited. So
Yeah,
I
you
skipped
are
the
right.
family history of cancer.
You are right. But in any patient with oncology, remember that go for the
Other
family
cancers.
history. Yeah, other cancer histories. So this is what the table, particularly regarding the postcoital, you need to remember these points, that important medication,
Mm.
her current medication, her any bleeding disorder,
Mm.
cervical smear
Mm.
history, sexual history, contraception history, what is her
Mm.
one is presenting complaint, and then other related, and HPV vaccination is very important. Next, move to
Yeah, I
this
forget.
point. Now, her question for some intimate partner violence. These patients may be suffering from some violence, some in the post for fear or so humiliation, afraid, rape, and kick. Have you ever been humiliated emotionally or abused in other way? Or have you been afraid of your partner rape? You can ask simple question. I would like to know her relationship with her partner, and will rule out any humiliation, whether she's afraid, any history of
Mm.
rape, any kicking
Mm.
history, to rule out any violence as a cause of
Mhm.
bleeding. Now, abdominal
Mhm.
examination, you will perform inspection. And abdominal examination, you rightly said that general look, cachexic, muscle wasting, any wasting, ask about loss of history, appetite, then abdominal examination, then in examination of the genital tract, inspection of the vulval skin, like any dermatosis, excoriation, ulceration, fissuring,
Mm.
coscospeculaum examination, and you will inspect the vaginal wall, laceration, prolapse, cervical ectopy, polyp, any cervical growth, postcoital bleeding are clinically apparent on speculum. Examination findings suggestive of cervical cancer, including ulceration, friable tissue, contact bleeding, Craigie irregular mass, bimanual examination. You rightly mentioned that I will assess the size of the uterus, mobility, any hardness, and the size of the consistency, and the mobility of the uterus. You will assess on examination. Now, history and physical examination, you will take the swabs. If you find any, if the patient is
I mentioned.
positive, yeah, you will take the swabs. Cervical screening test is overdue. So this is what you will do for your test. And if at abnormal result, you will refer to colposcopy. You refer this patient to colposcopy in your conversation while answering me that I will refer her. No, you will do cervical screening test. And if that gives you abnormal result, you will take her to colposcopy.
Yeah, then we will do. Yeah,
Clinically,
you are right.
remember this point. Clinically abnormal cervix, you will go for colposcopy. Like if you
Beautiful.
find some
Okay.
mass, definitely you directly, if you find some friable tissue, if you find some eroded edges that not looking normal, you will not go for cervical biopsy. You will directly go for
Yeah.
colposcopy.
Hmm.
Now, if the patient has a normal cervix but persistent postcoital bleeding or coexisting IMB, intermenstrual bleeding, transvaginal ultrasound plus minus Pipelle biopsy plus minus hysteroscopy. So this flow chart is important because they can take you to the examiner can give you, now she has this type of cervix, now she has the normal cervix, but she still have persistent postcoital bleeding. Her smear is normal. So what is your next step? You will go for transvaginal ultrasound. And then depending on the scan report, you will go either for Pipelle biopsy or if the patient age, I'll recommend you for hysteroscopy. In the context of postcoital bleeding, women require a colposcopic assessment within 2 weeks if the appearance of the cervix is suspicious examination. Now here to speak 2 weeks word is very, very important. The NHS cervical screening program advocate women with persistent postcoital bleeding or vaginal discharge in the absence of other pathology to be referred for examination by a gynecologist experienced in the management of cervical diseases. For example, a concern-led gynecologist. Gynecologists may refer these women for symptomatic colposcopic examination outside the cervical screening program if cancer is suspected. So you will refer this patient to a gynecologist who is able to manage these patients or who is expert, who has this field of expertise. So remember, 2-week pathway, you will refer her to the, if there is no NHS cervical screening, a woman with persistent postcoital bleeding or vaginal discharge and there is no pathology, you should refer to be examined by a gynecologist. Remember this pathway. Now, what are the risk factor? Major risk factor are early onset of sexual activity, multiple sexual partner, family history, smoking, low socioeconomic status. What further investigation?
My family history, we will mention that in that situation.
Better. It's, there is any harm in mentioning family history? No harm. Even if you
No
speak,
harm. Basically, the cervical cancer is not
it's not
inherited, so that's
familial.
why.
Yeah, but I have taken from this. I don't know about the recent strategy, but when I prepared my slides and my notes for the cervical cancer, there was one risk factor of family history. Maybe it's not.
Okay, fine.
You don't want to mention
Okay,
no
fine.
harm, and in my opinion, if
fine.
you mention no harm in
Better to
mentioning.
mention. Okay.
Better to mention. A visual inspection of the cervix and vagina you will do along with bimanual vaginal examination to assess vaginal and perimetrial. According to the new guideline which is published by the BGCSE, they have changed these lines and it's very important. Rectal or rectovaginal examination is strongly recommended, especially when assessing large tumor or if there is uncertainty on bimanual examination. MRI is more accurate than CT scan in pre-treatment local staging of cervical cancer. Preoperative chest radiography is the part of staging and should be performed in all women with cervical cancer prior to surgery. So remember, visual inspection, speculum examination, rectal vaginal examination, MRI in pre-treatment, and CT scan of the chest or chest X-ray is required for staging and should be performed. And these are the lines which I have taken from that very recent guidelines, and these are the changes which they made. Patient is diagnosed with stage 1B. Now, the stage 1B treatment for stage 1B and 1B2 cervical cancer is radical hysterectomy and bilateral salpingectomy plus minus bilateral oophorectomy with bilateral pelvic lymphadenectomy. Younger patient, opportunistic bilateral salpingectomy should be discussed and offered, but radical trachelectomy for a woman who want to preserve her fertility with cerclage. You did not mention cerclage. Radical trachelectomy with cerclage and bilateral pelvic lymphadenectomy are sentinel lymph node biopsy is an option for the patient with cervical cancer up to stage 1B1 who wish to preserve the trachelectomy may be an option also for 1B2, but that is quite advanced stage now. No, don't go into
So,
much
Dr.
detail.
Khalda, just first we mentioned the general options also, as the questions mentioned suggest the patient want to preserve the fertility. So
No,
I
the
did not
examiner will
mention the
put you
other
direct
options. So we
questions.
should mention the other options also.
If you have if the examiner don't ask you directly that this woman want preservation of fertility, then you have to mention both options.
In the
But
question, it is mentioned that she want to
preserve fertility, so you will go. So you will get that there are usually the treatment for this is hysterectomy and bilateral. But for my patient, the recommended treatment is radical trachelectomy along with the, there is what you want to say to the examiner, and if you want to show your knowledge to the examiner, there are ways to tell them. And one way is that you don't want to mention You want to tell her about a woman who want to preserve fertility, but in the same sentence, you can take out that
We will
word of
mention other
hysterectomy
points
along
also.
with bilateral salpingo-oophorectomy and pelvic lymphadenectomy. So you can, in the same sentence, if you, because in structured discussion, you have time, you finish 1.5 minutes before. So you still have time, so you can speak few sentences. If you think that you've not long time passed, you can speak, and there are ways to speak, because the
Yeah, get
candidates
your
are
point,
always
ma'am. Yeah.
asking this question: what I should speak, what I should not speak. Even if you
Yeah,
want to
this is
show
the
to the
point.
examiner, there are ways to speak to the examiner or to the role player. Making your sentence, arrange your sentence in this way that you want to show to the examiner that I know many things, and but being stick to your patient. Now, serial ischemic. Now, this trachelectomy is done now. MDT involvement. Serial ischemic are neocervical length scans twice weekly. Fortnightly. Vaginal progesterone. This is very important. From 12 weeks till 36 weeks. Urine and vaginal infection to be treated early. Avoid spas and swimming pool. Bed rest is avoided. Steroids. Avoid digital examination. Avoid sexual intercourse. Avoid strenuous exercises. Avoid effective dental work. Thromboprophylaxis in the form of TED stocking. Mode and timing of delivery, or you can say thromboprophylaxis assessment and treatment prophylaxis according to the score, mode and timing of delivery to be delivered by cesarean section, psychological counseling, and peer support group. This is general information about the different stages of treatment, and then that's all from my side. If you have any question, you can ask. But postcoital bleeding,
No, ma'am. Yes, clear.
one of the
Because I did
important
it quite
talk.
before. Just I
Yes,
try.
but still,
Thank you
once
so
you will
much.
go through
Yeah.
it, even if you don't go through whole talk, just go through this
Just
table
tables.
and remember
Yeah.
that points of information gathering, then what you have to do with, because the examiner can take you to the anything. He may take you to the cervicitis. He may take you to and cervical polyp. He may take you to the cervical carcinoma. He may take you to STI. He can take you in any
This
direction.
would be the multiple reasons behind the postcoital bleeding.
So you should know about all the reasons, and the shortest way to
Ma'am, so first
have
we should put the differential, and then we will say that it could be
yes,
the
you will tell,
these
yeah,
reasons, and I would
yeah,
like to gather the information from the patient.
yes,
Okay.
yes. These are
Get
possible.
your point. Thank you so
Yeah,
much,
these are
Dr.
the
Khalda.
possible differential. Now, if you don't have time, I would suggest all of the candidates who are listening to us that if you want to revise the talk, there are infographic given from the talks, which are very concise, very precise, and you can go through your end time, your last week of your exam preparation, go through infographic. Important points are all given in infographic, so you can even go through infographic, and at least you will not be blind if you get a station from a talk which you have not been able to study. So go through the infographic. First, my suggestion will be go through all the tables. If you cannot go through tables, then go through infographic at least. You will get some idea.
Dr. Khalda, hello.
Yes, yes.
Hello.
Yes, I'm listening, my dear.
Yes, ma'am. Kindly show me the previous slides also regarding the staging of the cancer.
You will get it in recording. You will get it. Let me show slowly so that this is the stage 1 in the standard management. I have put the management for every stage. This is the next stage. This is the next stage. That's all. I hope so. It's okay now.
Thank you so much, Dr. Khalda. So it's very beneficial for me, really. Thank you so much.
Welcome. You are welcome. So now Dr. Zubia will take it over, and I will start. Dr. Zubia, I hope so you can share your slides, because your slide is not downloaded with me right now. So I have to stop my
Okay,
share.
Dr. Khalda.
Okay,
Yes,
so
yes.
I will
Okay,
stop
yes.
recording, and then now you can start. I will change the host to you. Okay, I will stop
Okay,
my
ma'am. Okay.
share. I will change the host to you, and you start recording then. Where to change host, my dear? Tell me. Host, alpha, host only, host only. Okay, let me check. Maybe I will be able to do it for you or not. let me let me stop recording and I will show you. Okay, I will show your slide because it's difficult for me to change the I will stop recording. Just give me 2 minutes. Huh? I'm sorry, I'm wasting your time.
No, yes.
Yeah.